Thanks everyone for coming today. So my name is Rebecca Ralston. I'm excited to be with you. I was asked to give this workshop actually by my HOSA teacher instructor from high school. I'm really excited to be here. I was in your shoes many years ago and attended all of the HOSA conferences, which was a pretty big highlight of my high school experience. So just as we get started today, this is going to be hopefully pretty interactive. I hope that people will ask questions and speak. And the title here is So You Want to Be a Doctor, Here are 10 Truths. This is, we'll get into this on the next slide, but based on a Kevin MD article that I co-authored with some of my colleagues. We'll go ahead and start. So this Kevin MD article and podcast really just goes over some of the things about being a family medicine physician. And I'll start on this slide actually. So just to tell you a little bit about some of my roles and some of the exciting things about family medicine. I am a family medicine physician. I work at what's a hospital system called Cambridge Health Alliance here in the Boston metro area. I am originally from East Tennessee and I moved up here for residency and now am an attending physician. My hospital system is a publicly funded hospital, one of the two publicly funded hospital systems here in Massachusetts. And we serve a largely Medicaid, non-English speaking immigrant underserved population at my hospital. I'm currently working as a hospitalist physician, which means that I have certain shifts in the hospital. I see the patients, round on the patients, and admit them to the hospital there and take care of them during their stay. I trained in primary care and family medicine. My experience right now is a little bit atypical for a primary care physician, but I think that is one of the great beauties of family medicine, and that you are trained with this incredible breadth of information and training so that you can really take that anywhere after your residency is over. As part of my appointment and position at Cambridge Health Alliance, it is a Harvard affiliated hospital, the only Harvard affiliated hospital actually that is a publicly funded and community health system. And so I have a Harvard faculty appointment. I do a lot of teaching for Harvard medical students and some Harvard-based residents. I also serve as the editor-in-chief of the Harvard Medical School Primary Care Review. We're in a bit of a transition phase with the Harvard Medical School Primary Care Review right now. And that I have been really the only editor, the editor-in-chief for the past year and a half of that publication. We have now brought on a nationally recognized editorial board of people from across the country. So physicians, public health advocates, and then also students from across the country as part of that. And we are shifting to this model that is largely really publishing the voices of community health workers, community members, community leaders, patients, in order to really uplift and hear those voices of the people that you don't normally hear in definitely Harvard publications or academic publications, but also really in general. So we're really hoping to uplift those voices of people who we don't generally get to hear from. So over the past year, some of the voices that I've really been excited to hear about are people from the Navajo Nation. So we have some staff people there, also a store owner from Navajo Nation who we get to hear about the fruit and vegetable program at his store. We've also heard from the director of a domestic violence shelter in Wisconsin, and so many more places. And that is really the goal of this transition, is to bring on this board of folks who will be able to help create these networks so that we can really hear those voices of people from across the country. I also serve as the head of research at a digital health startup called Bicycle Health. So Bicycle Health is a digital health startup that's based in kind of two places. It started in California, is sort of headquartered here in the Boston area now. And we provide, as part of the clinical services, biopsychosocial integrated behavioral health and clinical health for persons recovering from opioid use disorder. As part of that, our providers prescribe buprenorphine, naloxone, also known as Suboxone, which is one of the three medications for people with opioid use disorder to help in recovery, and then also provide integrated behavioral health as part of that. And so, as in my role at the startup, I serve as the head of research. I'm leading all of our research initiatives. It is that I am the first person in this role, so it's a bit of a large endeavor as we take this on. But really looking at our clinical outcomes at the startup, and then also thinking about other things, especially the social determinants of health for our patients, how we can create this robust referral and case management system for our patients' SDOH health, or the social determinants of health, and a number of other things. And so we're collaborating with various different folks, also again from across the country. So we have collaborations with people who are Harvard based, with Rand Corporation, newer collaborations with some folks at Hopkins and OHSU out in Oregon. And so all of these collaborations are really exciting for us as we think about how to best serve people with opioid use disorder. And I think I forgot to mention this earlier, but it is all via telehealth. So that is really the goal of this model, is that we can provide buprenorphine to people in buprenorphine deserts where buprenorphine is otherwise not available. Okay, perfect. And someone just messaged me about my email, and I have that on the last slide. So people are welcome to email me after this. And then also, in addition to Bicycle Health, so I also serve as a reproductive health provider within my own organization, and then at a separate nonprofit organization here in Massachusetts, where I provide full spectrum women's health services. And so that is really exciting. I get to provide things like contraception counseling, LARCs, which are long-acting reversible contraceptives, and a number of other services to women, people who identify as women, or people along the like people who identify in various ways, really. Anyone who is looking for like family planning services, or desiring, even looking for more information solely about family planning services, we're able to provide that. And then lastly, in one of my newest endeavors, which is sort of the beauty right now of this hospitalist schedule for me, the reason that I chose it really is that I'm able to do so many different things. So I'll be going for various weeks throughout each year to the Indian Health Service on the Rosebud Reservation in South Dakota. So I'll be serving there generally for about 2 weeks at a time, sometimes 1 week at a time, but working at the Rosebud Hospital at the Indian Health Service, where I'll be providing inpatient care to the people there. It's about a 10 to 15 bed hospital, and it has sort of a newer partnership with Harvard. And so there are a number of providers, so physicians, nurse practitioners, PAs at the IHS hospitals. IHS stands for Indian Health Service. And as part of this Rosebud partnership in South Dakota, Harvard is sort of responsible for some of the academic nature at the Rosebud Hospital, as well as 3 physicians there at all times. So 1 inpatient physician, 1 outpatient physician, and then 1 physician who does 50-50. You'll see here that one of the main things that family medicine physicians do that I'm not currently doing is primary care. So primary care is really actually one of my loves of medicine. It's something that I'm not doing right now, as that I'm pretty new out of residency. I graduated from residency 1 year ago, this month actually. And so I wanted a job that would allow me to explore a lot of different areas. I do have a master's of public health from George Washington, and then I did my medical degree in East Tennessee, where I'm from. And I want to eventually be able to really have a lot of my work be public health based. So a lot of what I do now is very much public health work. I also do a lot of clinical work now, but I'm very much interested in this sort of higher level, population level health, social determinants of health, and how we actually create health for larger populations, and how I can be part of that. So I do provide this one-on-one or physician, patient, family, provider level care now, which I always plan to do to some extent. They'll also provide some sort of other like population level health, public health degree at large. So in the future, you might be wondering what that may look like. I would be interested in some sort of like federal government level job at HHS or other position working in public health. So we'll see where that goes. But that again is really the beauty of family medicine, and that you can really do anything with family medicine. So to just go back to my last slide, which we can briefly look at this Kevin MD article, and then later, if you're interested, you can listen to this podcast where Dr. Kevin interviews me. He's a pretty well-known like podcaster and writer within the physician community. So I think he's pretty popular there. But one of like the main beauties, I would say, of family medicine is that you're trained in really everything. What that training looks like is primary care. So you're trained from birth all the way through the end of life. As family medicine physicians, we're able to deliver babies. You can even get extra training if you're interested in doing C-sections. So you can do that as a family medicine provider, which is actually critically important right now, especially as we think about more rural areas or underserved areas where a lot of OB units are closing down, especially throughout the pandemic. And there are also a dearth of OBGYNs, like trained OBGYNs in some more rural areas. This is something that family medicine providers really can provide and are actually critically important to provide OB services. So delivering babies, doing C-sections is all within the scope of family medicine. We do well child visits, see kids throughout their lifespan, treat all really pediatric conditions that are within the realm of a primary pediatrician or primary care physician, and then also can provide inpatient pediatric care. I don't currently provide inpatient pediatric care. I just do adult medicine right now, but it is something that I'm trained in. We also treat adults throughout their life spectrum. So that includes things like family planning, some basic fertility services, and then a lot of psychiatric, social health, behavioral health concerns are really at the core of what we do in family medicine. Obviously, more medical concerns as well are things that we provide inpatient care, outpatient care, and then also as we start thinking about end of life, a lot of, I would say that really the majority of palliative care or hospice level physicians are family medicine provide or internal medicine trained. And so these are all things that we're able to do in family medicine. So it's really the beauty. Many family medicine physicians, or maybe even most, are involved in some level of public health, advocacy, policy, community health to a large extent. And so really integrating into the community, being advocates for their patients, being advocates for their communities is a large part of what we also do as family medicine physicians. And that is actually the reason I went into family medicine, is because of that ability and focus on really advocating for your communities. So just to take a very quick look here at the Kevin MD article, hopefully you all can see this article. So I co-authored this with some of my colleagues from the Harvard Center for Primary Care, also all family medicine physicians. We were responding to this article called "So You Want to Be a Doctor? Here 10 Myths Debunked," which is a little bit of a cynical view of being a doctor, and our experience is just so much different and so much broader as family medicine physicians, and we wanted to share that. So all of these points here are actually rebuttals essentially to the first article. So you'll see things about you'll be rich, you'll save lives, all your patients will be grateful. I don't want to go through all of these points. You can read it yourself if you're interested. But essentially, being a family medicine physician allows us such great it's this great sort of honor to be able to be with patients, be with our communities, and really truly actually make a tangible difference in the lives of people and in the lives of our communities. So just to touch on some of these points, you'll be rich. Obviously, there's no lack of knowledge in this country about the sort of insane amounts of money that physicians make, which I don't think are necessary by any means, but it is how our healthcare system is sort of unfortunately set up. You'll save lives. So really that is something that you might not be saving a life every day, but you really are impacting the lives of people on a daily basis as a family med physician. And at times you are really actually saving lives. All your patients will be grateful. Clearly, not everyone is always grateful, but you do get to develop these very close-knit relationships with your patients, and oftentimes with your communities. Everybody will love you. Obviously, not everybody will love you, but it is, again, you get to have those very tight-knit relationships that are very intimate relationships on this patient-provider basis, getting to actually be involved in some of the most sort of intimate details of people's lives in terms of childbirth, families, school, other personal decisions as people go throughout their life spectrum. You'll make the world a better place. So I think we've already sort of touched on that about the types of impacts you get to have as a family med physician. You'll inspire others. Again, same thing there. You'll be respected and trusted. You'll always be proud of the work that you've done. Clearly, no one is always proud of the work that they've done, but I think as family medicine physicians and evidence-based physicians that we are oftentimes able to feel proud of the types of impacts we're having, the sort of education or care we're able to provide to others. This was sort of an interesting one that the original author had included, but everyone will want to date you. Sort of personal lives are a whole separate topic that if people wanted to, especially like navigating sort of this sort of professional path as a woman has had its obstacles and interesting moments, especially coming from a very sort of like socially conservative state myself, where many women do not actually pursue medicine, has had its ups and downs, but we do as physicians and family medicine physicians actually really get to focus on our personal lives as well. And for many people that includes families and including women physicians who get to still like have that part of their life if that's something they desire. And then as a doctor, you'll have a healthy lifestyle and set an example for others. So that is also something that we obviously get to choose whether you do have that healthy lifestyle or not. But as family medicine physicians, that work personal life balance is something that we actually really value. As family medicine physicians, we really understand the importance of that balance and people are supportive of each other in those endeavors. So I'm just going to close this. We'll try to go back to our PowerPoint if it's still here. Perfect. And then, like I'd said before, there is this podcast where I talk for about 15 or 20 minutes with Kevin, MD, about some of the different things I'm involved with. And I'm also happy to chat more about that today as well. And so now I was hoping that we have about like 9 minutes left of the more formal presentation. I can stick around for a little bit afterwards as well. But I'm wondering if there are questions that people have. Obviously, what I've talked about today is being a family medicine physician. I did definitely explore other areas of medicine. I nearly went into OBGYN because of my interest in women's health. And I'm happy to answer questions for people as well about why I chose family medicine over OBGYN. I also thought about going to PA school rather than medical school, because back to sort of that work personal life balance, I was to some extent, or even maybe a large extent, the people around me once I got into college. This wasn't actually the case in high school, nor was it so much in medical school, but the people around me in college, also again in East Tennessee, and within the medical community itself, had almost really discouraged me from pursuing medicine because they said that as a woman, I wouldn't be able to have a personal life or a family, which is extremely far from the truth. So I did explore some other paths as well, because that's something that's important to me, to be able to have a personal life in addition to my professional life. So if people have questions about that, or navigating that as a woman professional, which is often more difficult in this country, and in specifically some parts of this country, then I'm happy to chat about that as well. So I'll take the PowerPoint down. You're welcome to email me. This is my email address here. I can also try to put it in the chat so it might be more accessible, but it's essentially just R for Rebecca, my last name, at CHA, which is .harvard.edu. So CHA stands for Cambridge Health Alliance, which is my hospital. Okay. So there are just a few questions here in the chat. So first of all, let me just put in my email address. Okay, so there's my email address. You're welcome to email me. Someone, Varsha, said, as a sophomore, I've developed an interest in neuroscience. So how can I get experience in it? So that's a great question. First of all, I think as a high school student, and being part of HOSA is really one of the best things you can do. HOSA and the medical classes at my high school, again in East Tennessee, were really the best part of, or really helped to guide my way in medicine, I would say. For people interested in neuroscience, I would say you could start by looking for those connections. If your clinical teachers or your HOSA instructor has any sort of contacts, which they probably do in your specific area, for neuroscientists or neurosurgeons or a researcher in neuroscience, they getting connected with that person can actually be really helpful. If you're interested in more of a virtual experience, I could also try to help with that. At my institution, we do really focus more on like primary care, but I think looking at other like larger institutions, so if you have a larger institution in your area, or even just like a larger institution that's known for neuroscience or whatever it is that you're interested in, it can go a long way with sending emails to, say, a person or a mentor that you identify, which I actually highly encourage. I think that sending cold emails to people that I don't know, and that you think may not respond, can go a long way. That's honestly, I would say, how I've also gotten a lot of opportunities throughout my lifetime, is by sending emails to people, whether I thought they were going to reply or not. And a lot of them do. I would say most people reply to emails if they have the bandwidth for it. If people don't reply, it's often just because they missed your email. They're just so busy, they don't have time. But I think that most people are actually really interested in mentorship, and at least sort of trying to direct you to someone who could provide that mentorship. So I think looking at your HOSA instructor for that, you're welcome to email me, though I do have to admit, again, my experience is largely within the community health, primary healthcare sector, though there are clearly lots of neuroscientists at Harvard that I don't know directly. And then really just doing a Google search of people in your area or at larger institutions who have that experience that you might look to as a mentor. And sending those emails, identifying yourself and including that you're a HOSA student, you're interested in this field, and you're hoping for a mentor. Um, and then someone said, how did you balance having a child and the medical profession? And so I would say, first of all, the child in that last photo is my nephew. I don't yet have children. I plan to have children. And and so that can be tricky. I think that we could have a whole session on women in the medical field, and it's hard. It can be harder at times. I would say, like most of the uh, about 3/4 of the students in my medical school class were men. About a quarter of us were women. One of those women had a child in medical school who had a stay-at-home husband, and a lot of the men in my class, their wives had children in medical school. So there's clearly a disparity there. Some of my residency colleagues had children in residency. My women medical colleagues, that can also be tricky. I think looking for a residency program that's supportive of family and supportive of women is really, really key. And I see Varsha's next question about, is it hard to get into neurosearch as a female? And so I think really, and I'll address that more specifically in a second, but I think that thinking about when we look at residency programs, do they have women in their programs? Will they be open to like families having kids in residency? And then thinking about that experience if you're interested in having kids in residency. If you're interested in having kids after residency, I think that's sort of a whole different ballgame in which things are a little bit easier. So I'm after residency now. I didn't have kids in medical school or residency. And so now I have the ability to really choose my schedule. It's more flexible. My pay is obviously better now. My hospital, unfortunately, does not have paid maternity leave. And so that's something that I'm advocating for like pretty hard, as it's clearly important. And most other peer countries to the US do have that. But it's still possible. So I think having a supportive partner in this is also pretty key. If you plan to have kids within the medical profession, either having a supportive partner, having supportive family members, easier said than done most times, but that can also go a long way. So I'd say it's definitely possible. I'm still quite young when I'll be like having children, and so just keeping that in mind that lots of women do it. Actually, there are more, I think the medical field has slipped slightly more towards women than men right now. But as we think about in what specialties those women are, many women are largely in primary care specialties or non-surgical specialties. So to get to Varsha's question about, is it hard to get into neurosearch as a female? I actually think neurosurgery, in my experience, I have a medical school colleague who's in her last year of neurosurgery at Mayo, actually, which is one of the best neurosurgery programs in the country, that neurosurgery actually tends to be a little bit more open towards to women than some other surgical specialties. So if you want to go into neurosurgery, that's great. You can, I think that's like totally doable. And the medical field right now is highly aware of the fact that women are not going into surgical specialties as much as men, just because of this ability that surgical specialties tend to not be quite as welcoming to women who want to have kids, which is harder because men can have kids clearly without taking much time off work. For women, that can be a little bit harder. And I would say the medical field, including the surgical fields, are acutely aware of that. Some change is faster than others, but neurosurgery is actually something that I think is much more open to women than some other more stereotypical surgical fields. And obviously this is my personal opinion, and it's a little bit stereotypical, though I do have many, many friends in surgical specialties. So someone sent a question, do you know if there's anything specific you have to do in college or in general to work in the ICU as a doctor? So no, there's nothing specific you have to do in college or high school. So to be an ICU doctor, what that ultimately entails is doing, most people do internal medicine residencies. Actually, family medicine doctors can also work in the ICU. But after there's a specific sort of intensive and often intensive and pulmonary care is combined together as a fellowship. And so one of my best friend from medical school, she is in her going into her final year of pulmonary, it's called pulmonary and critical care medicine. It's a 3-year fellowship after internal medicine residency. And she's also going into her last year of that. So you would ultimately pursue likely the internal medicine specialty and then do a fellowship after that. Megan wrote, did you have any challenges getting into medical school? Do you have any advice for getting in? And so I would say for everyone, it's a challenge to get into medical school. My husband's actually considering going back to medical school at this time. He's already a lawyer, but now he wants to be a physician. And so getting into medical school is really challenging for anyone. But advice for getting in. So I think it's really, first of all, being in HOSA, like as a high school student, is huge, really quite huge for getting into medical school. That helps you think about how you want to shape your experiences in college and what classes to take, what mentors to look for. I think shadowing people in different fields of medicine is also really helpful. So that can be a little bit easier said than done, though again, identifying physicians or other providers in your area who would be welcome to having you shadow them. It is actually, most people are open to that if their hospital allows it. And so talking to either your HOSA instructor or reaching out to physicians on your own. Maybe that is just physicians you don't know that you found on Google. Maybe it is family friends or something like that. But shadowing physicians can be really helpful. Other advice for getting in, obviously, like doing as well as possible in your college pre-med classes is critical. Studying for the MCAT and doing as well as possible on the MCAT is helpful. But then also, in addition to that, medical school these days, luckily, are shifting more towards valuing people who are well-rounded. And so having well-rounded experiences, whether that's in terms of research or extracurricular activities, advocacy work, policy work, all of those things really help in getting into medical school. Some people go straight through from college to medical school. Some people take 1 year or more years off. I personally took 1 year off and traveled for the year. And that was because I didn't decide to go to medical school for sure until my graduation week of college. Again, really relating back to these like pressures of being a woman in the medical field that were coming from my communities. So I think all of those things can be helpful, but I would really also place some importance on like where you spend your time, what you do as your extracurricular activities. Many people applying to medical school have very good grades, very good MCAT scores. And so that itself might get you a second look at your resume or will get you a second look at your resume. That's going to be like a first pass, is getting those good grades, getting a good MCAT score. But then also what's going to get you an interview and ultimately into medical school is having this sort of other breadth of experiences, or whether that's life experiences or other sort of volunteer extracurricular experiences that you can talk about that have really shaped you as a person. And I just want to sort of mention about grades and MCAT scores. Clearly, the best possible grades and scores are good. But if you get like a bad grade in a course, or you have some sort of like, say, personal or family emergency that prevented you from finishing a course or getting a grade that wasn't the highest you could get, all of those things are also understandable by a lot of medical schools these days. And so if you have some sort of situation like that, then explaining it actually in your medical school application also goes a long way. If we're interested in peds, would you recommend pursuing a career in family med and just focusing more on peds as opposed to adults? or would you recommend choosing a pediatrician career more similar to a pediatrician? So I think that's really totally up to you. If you're interested in pediatrics and all you want to do is ever see pediatrics, then maybe being a pediatrician is a better fit for you. But I think being a pediatrician, they still obviously have an important focus on primary care and public health, which is great. But you could also do the same thing within family medicine. So if you wanted to be a family medicine physician that just really focused on pediatrics, you could do that. I think that depending on the community in which you wish to work, like say in the Boston area here, if I said as a family med physician, I just want to do pediatrics, there are definitely jobs I could get where I would just do pediatrics. If you're more in a rural community where there are fewer doctors and you're family medicine physician trained and you say, I just want to do pediatrics, then you might get some pressure to be like, well, we also need a doctor who can see adults as well. So I think thinking about the community in which you serve is really key. The pediatrics training is changing just a bit, but historically peds has had a little bit less focus on like adolescent sexual health and family planning in that regard. I do think it's changing, but I think keeping in mind that if that's an interest of yours, just also to be pursuing opportunities, whether it's in like peds training or family med training that allow you to be able to actually talk with your adolescents about sexual health. What was the biggest obstacle you had to overcome during your high school or college experience? So I think probably one of the biggest obstacles. My high school experience was quite pleasant. I did move in 8th grade, which was not a pleasant experience. I moved from Maryland to Tennessee at that time, which I wasn't a big fan of the transition. But once I did transition and made new friends in my new school and new home, I came to love my high school. So my high school friends are still some of my closest friends today. My high school I still absolutely adore to this day and think it set me up for really the success I've had to date. My high school did. And my college experience, would say had some more obstacles just in terms of a little bit oddly, but my college experience was a little bit more on the religiously conservative side because I did go to it was like a religious private liberal arts school. And so there were fewer women pursuing a medical profession. There was a little bit more pushback about why I was going into this long professional path, and a number of other things about like why I wasn't married and why I wasn't having kids at the age of 22 or 23, which is what most of my friends were doing at that time. So I think that had over time like a pretty big psychological impact on me, to say the least, because it's hard to pursue something that's different for when we start thinking about professions and then also thinking about gender equality in this country. So I'm happy to talk more about that to others who are interested. But that was definitely, I think, one of the bigger obstacles, and ultimately almost derailed my going to medical school. Luckily it didn't, because I'm really happy with where I am today.
5 minutes until the video ends.
Okay, thanks.
Okay, sure.
What were some of the things or research you did during school to create a good resume for medical school and residency? So I think something that when I went to my state school, so I went to East Tennessee State University, which I loved as medical school. I think getting into medical school, some things I did, I did well in my classes. I honestly didn't do quite as well on the MCAT as a lot of my peers. But luckily I still got into medical school. I only took it once because I took it at the end of the summer after I decided that I was going to go to medical school for sure. And then I was involved in a lot of extracurricular things. So I did some research. It wasn't quite as robust research as some of the other people I meet here in Boston doing, obviously. But I was involved in some research experiences. I presented papers in college, so I would go to conferences and present papers or make presentations. I was also involved in a lot of advocacy work in my community, which I think is something that's really important to medical school, especially these days too, as we start thinking about physicians as advocates in their communities. So there aren't really specific things that you have to do, but I do think those sort of like bigger buckets are helpful in getting into medical school. Besides residency, is there a good way to get experience before becoming a doctor? So you definitely still get a lot of like medical school. Half of it is clinical, like full clinical experience. And so you get a lot of experience in medical school. You're basically trained to be ready to be a doctor on day one of your residency. And you just get better and better after that. I think the main thing you can do right now, thinking about clinical experiences, is asking to shadow people in your community. So whether those are any sort of healthcare professional that you're interested in becoming, shadowing that type of person is really helpful. Do you have any resources for high schoolers to identify potential research topics, as well as how to proceed? So I think in terms of research, the most important research you can do is research that you're interested in. So I think what happens a lot for pre-med students is they think like they have to do this basic science research, bench research. They just ultimately do whatever their like college science professors are working on, and they do that. What I would actually recommend though is identifying some of your interests. So whether those are clinical, public health, maybe basic science interests, and then looking for someone, whether it's in your area or whether it's nationally, who's really focused on that as well, and asking if you can be part of it. So right now, actually at the startup, at my startup at Bicycle Health, I'm working with a high school student. I think he's like 16, and he reached out to our founder, which that's like, he sent a cold email to our founder, who responded and said, sure, you can be involved. Our founder then directed him to me, who's in charge of the research, and he's working with me for the summer. So I think that reaching out to people who are working on things you actually genuinely have interest in goes a long way. Okay, so how much did you study for the MCAT, and how difficult was it? First of all, so I mean, it's extremely difficult. It's the hardest test you'll ever take, and I studied all summer for it. And there are different ways to study, which we could have a whole separate session about how to study for the MCAT, but I would recommend taking an MCAT course and plan to study for at least like 2 to 3 months minimum. Do you know of ways or jobs to combine law and medicine, and can you do both in a career? And yes, you can absolutely do both law and medicine.
Thank you so much for your presentation. You are amazing. And I'm so sorry that these are timed, but I just want to tell you it's about to go. So thank you so much. We appreciate you.
Yeah, of course. People are welcome to email me afterwards with their questions.
Thank you. We really enjoyed it.
Okay, thanks.
Bye.
Bye.